Our last presentation for the afternoon is Dr. Brian Eastridge. He's going to talk to us about trauma system preparedness for mass casualties.
So again, I want to thank the organizers for the invitation to speak. And what I was specifically asked to speak about, gave the organizers a list of about 10 things, and they really jumped first at this one, is really to tie in preparedness on the systemic level with the lessons learned from the Sutherland Springs active shooter event. So it's been it's a year this week that we had a terrible tragedy in our community. Actually, it was Monday, and Monday, actually, several of my partners, many of the nurses that were involved, EMS agencies, everybody was keenly aware of the significance of the day, as several people actually had to take the day off. These types of events, they tend to be ingrained in your memory. On the anniversary occasions, they tend to be a little rough to get through. So I want a couple of acknowledgments to a couple of my partners, Dr. Ronnie Stewart, that many of you know, and Don Jenkins, and Eric Epley. Eric Epley is actually, we have a very sophisticated trauma system in our community. Eric is the executive director of that trauma system. I don't have any disclosures. Also, as a disclaimer, this is my presentation along with some work with Dr. Stewart and Dr. Jenkins and Mr. Epley, but doesn't represent any of the state findings or official law enforcement findings. So one of the biggest things that we have to contend with when we're dealing with mass casualty incidents is thinking that it'll never happen to us. I think everybody that's been in one of these situations has really sort of had that feeling that this happens somewhere else. We read about this on CNN, we see this in the news, but it's not going to happen to us. And so we need to keep that in mind. We need to be thinking, what could happen? How could this happen? How could this transpire where I live? And if so, what would I need to do? What would we need to do to be prepared for that eventuality? And again, the lack of this insight is clearly been noted before with, again, you see the quote there from Frank Borman, but also the 9/11 Commission said, we should have been able to see this coming, right? The Twin Towers have been a target, they've been targeted several times. How could we have let this happen? So with respect to the 9/11 Commission findings, they said we need to be imaginative when we're thinking about conceiving our risks to our communities. We need to develop policies around the infrastructure for response and prevention. We also need to develop capabilities, and we also need to be able to manage these things. And when you put them all together, the imagination and the policy is really the planning part, okay? It's important to have a plan, but a plan is a check of the box. It's what we do basically to pass a credentialing visit or something. But every plan will ultimately fail because that specific scenario never happens, right? There's always some nuance to that. So you have to be able to be adaptive to the eventuality of your plan failing. And then the capability and the management is really about preparedness and response. And again, this concept that plans are important, but really having the capability to be adaptive is really one of the core tenets of war. It's one of the core tenets. It's certainly one of the core tenets of planning to be prepared or preparedness. Now, putting this in the context of the modern trauma system, the pillars of a modern trauma system are prevention, acute care. So when an event happens, we have to have the infrastructure, we have to have the pre-hospital systems, we have to have the hospital capability to manage that. Then the post-convalescent, And all of this becomes the framework for disaster preparedness. So really what we do on a day-to-day basis are really just sort of microcosms of disaster every day. I mean, the car wreck out on the interstate with 3 to 5 people that you have to take care of, again, you go through the same principles. Disaster and MCI is you just ramp that up to a greater level. So how are they similar? Again, trauma is about prevention. Disaster, again, mitigation on a larger scale. When we talk about acute care or trauma, our acute care is analogous to the response phase of disaster management. Rehabilitation is recovery, and so on and so forth. So trauma system and your local disaster response are actually fairly similar. So we all know from the last 50 to 60 years of trauma system development, which were largely born out of the successes of evacuation and care in Vietnam, have proven to reduce mortality. So communities that have trauma systems actually have better outcomes for injured patients in those communities. Those trauma systems actually required structured cooperation and communication. This includes amongst even competing hospital systems. When it comes to an MCI or a disaster, it has to be about the greater good of your community and not about other parochialisms within those systems. So really, the trauma system is not conceptually different than the disaster response. It's basically just on a more grand scale. So disaster pitfalls. Again, and this is why it's important to have a plan, but planning is more essential. They're all going to be different, and they're probably going to be different for all of your communities. As a matter of fact, if each one of you think about what's the liability in my community, you probably all have 100 different answers based on your communities. Planning is essential, and really remember when the event happens, it's happening to you at your location in your community. It starts very local. The response is going to start as a local response, and it may have to evolve depending on the size of the event to a regional, state, or a federal response. But all disasters start locally, both in the event itself and the response. The primary goal is medical. Obviously, the most common thing that you're going to be dealing with is physical trauma. And one of the biggest issues that's been shown time and time again to be a liability in the response is communication. Communication, no matter how good your communication system, it's going to fail. So you have to be able to adapt to that. Or it may not fail outright, but it's not going to be what you expected it to be when you were making your plan. And then you have to train and collaborate. So I know all of us who work in hospitals, we have to do disaster drills as part of our credentialing process. I would implore you to do those with some degree of realism. Carry those scenarios into your hospital. Don't just pencil whip the exercise for the credentialing visit. So the things you have to ask yourself, and it's different for all of us, what are we preparing for? What's our local threat? Are we prepared? Who's actually going to respond, and who's responsible for that response? And again, are we working together? And this is just from one of our talks that we gave just before that we were actually discussing the Texas disaster response, because Texas has so many federal declared disasters, actually the number one state that's had federally declared disasters. Remember that we're dealing with sort of disasters on a small basis every day. The disaster response should be a mandatory part of the trauma system structure. Too often, disaster response and the trauma system or the trauma care are disparate parts of the hospital system. They really need to be very closely integrated, because if you think about it, it makes sense. If you have a disaster in MCI where people are injured, who are going to be the caregivers? The trauma service, the trauma team, the nurses, the physicians, the other care providers. So those two systems have to be very closely integrated. So with respect to the incident itself, a local incident really takes dozens of actions to actually effect sort of resolution of the incident. As you move on to regional, to get the regional response and ultimately a federal response, when you get to that level, those things take literally thousands to hundreds of thousands to millions of events. So the role of trauma systems they're committed to improving the local care of patients. They advocate for the effective care in the trauma in the region. And so that's why your trauma system really has to be tailored to your region. It's important that there are champions in your region for disaster management and preparedness. And you have to bring other agencies. We think of a trauma system and a preparedness response largely as a medical event. It's much grander than that. We have to integrate law enforcement. We have to integrate government. We have to integrate other agencies that are going to support that response. So this is just sort of an overview of our system in Southwest Texas. It's called Southwest Texas Regional Trauma Advisory Council. It's 22 counties, 26,000 square miles. The hub is there in Bexar County, which is, you see all the pins in, which is in which the city of San Antonio resides. We also take care of the large majority of what we call the valley, so the southern tip of Texas, which is another 20,000 square miles, because they are a largely underserved community. So just a couple of brief vignettes about active shooter incidents. Again, they've become more and more prominent. There was one that actually occurred while we've been at this conference. 98% of the offenders act alone. They've generally planned the attack. Most of the time, they actually have observed there's been some sort of erratic behavior, abnormal behavior. Many actually take their own lives after the event. And they're usually looking for a high body count. They're not looking to take hostages. They're not looking to get away. Many of the times in these contemporary active shooter events, they're basically just looking for the notoriety of a big body count. Again, because of the sort of the morphology of this, or because of the sort of this paradigm, there's a higher incidence of relatively lethal injuries. So lots of torso injuries, lots of traumatic brain injuries. There's a very high ratio of dead and severely injured. There's a greater requirement for life-saving intervention. So when your scene response is going to take a tremendous toll on your law enforcement and your EMS communities. Now this is just the graph the cartoon at the top left shows the FBI analysis of active shooters in 2013, and in the bottom right is 2016. And you can see that even in those years, we have 60 new incidents, 443 casualties, and 175 of those were killed. So it's a significant public health problem in our country. The escalation of active shooter events has been more and more prominent of late. These are the top 10 mass shooting events in our country's history, and you can see that the large majority of them have occurred since the year 2000. And again, our event and Parkland, which occurred shortly thereafter, again ranked right up in those with the highest number of killed in active shooter incidents. So, I'm going to forewarn you that I'll probably have to pause a couple of times going through this. Sutherland Springs, this is a sort of how the the system response to our MCI, which occurred on November 5th of last year. So this is Wilson County, and Sutherland Springs is there on the bottom right. And literally, most of Wilson County is that picture at the bottom left. It's just open plains of scrub brush and some farm-to-market roads. There's very little there. And literally, that is Sutherland Springs, right? The church there and that little community around that is Sutherland Springs. You wouldn't even recognize Sutherland Springs unless you had to actually slow down, because in every little community in Texas, the farm-to-market roads are 70 miles an hour, but as you get into town, it's 30, and there's always a state trooper there. So that's how you recognize some of these little towns. But other than that, you'd actually miss it. So, there you go. So the First Baptist Church of Sutherland Springs on that morning in November 5th, the assailant parked his car there at the yellow X. He got out of his vehicle and he walked over there to basically the side of the church and fired numerous rounds through the side of the church, and we know that because there's hundreds of shell casings on the outside of the church, and then proceeded to walk into the church and began to systematically assassinate people within the church. There were about 50 churchgoers in the church at the time. He managed to injure or kill almost everyone. The only reason that actually this event stopped is because at that little green blast there was a Good Samaritan who actually happens to work at University Hospital. He's a plumber and happens to live in Sutherland Springs, but he actually took his weapon and actually engaged the shooter at the front door of the church, at which point the shooter disengaged, got in his vehicle, and actually left by the white path. And at this point, we think that the shooter was actually probably grievously injured by the engagement with the Good Samaritan. And the Good Samaritan probably saved dozens of lives just by being there in his response. Again, you can see those are the yellow tags are the cartridges found on the outside of the church. It was thought that he probably fired about 450 rounds in about 10 minutes. And you can see those the green dots on the church door, those are rounds that actually went through the church door. So this is just a couple of photos of Sutherland Springs. You can see the law enforcement response. The picture at the top is actually the congregation in happier times before this event. And the picture on the left is a little boy named Ryland Ward. The first law enforcement officer on the scene when this got transmitted out was actually a local game warden. He was the closest law enforcement officer, responded, thought that the scene was probably cleared by the reports from the scene, but actually cleared the church and then started administering first aid. In his first aid, basically he got the tourniquets out of the trunk of his car and actually applied the tourniquets he had and started to apply first aid. In the meantime, there's numerous law enforcement, numerous EMS agencies that were on the way by mutual aid, because Wilson County, and particularly Sutherland Springs, doesn't have a fire department. They don't have an EMS agency. The closest EMS agency is actually the fire department in Stockdale, which is about 8 miles down the road. So ultimately, EMS was staged, and after the scene was secured, EMS was allowed into the church, probably about 10 to 15 minutes later. The Assistant Fire Chief Rusty Duncan was the Assistant Fire Chief at the Stockdale Fire Department and rushed into the church looking for any survivors. When they first got in the church, they didn't think there were any survivors just because of the scene. And he's walking up and down the rows. when a little boy reached out from under his mom, who had shielded him, and grabbed Rusty's leg and asked for help. That was Ryland Ward. Ryland was very seriously injured and had initially survived, no doubt, because his stepmother had shielded him and laid on top of him. She was ultimately killed. So Rusty immediately pulled Ryland out of the church, and it was obvious that his wounds, he had terrible wounds. He had numerous gunshot wounds, and he's a tiny little 5-year-old boy. So Ryland's survival is on the clock at this point. So this is the first information that comes out of Sutherland Springs. That's right, you can't read that. It's because it's really sort of the fog and the panic of what's going on. All of the information coming out of the system was gibberish. You ever play that game when you were a kid about, past the communication chain, and by the time you get to the end of the row, the message is totally different? That's really what was happening here. So we learned, and we have we thought we had a really great communication system, but right up front, we were getting misinformation, disinformation, no information. But we really had to start our preparedness response because this was something out of the ordinary, and we knew something was probably happening. So we find out ultimately that about 11:20, the shooter's across the street from the church, approaches the church, shoots many of the churchgoers, and you can see there's the law enforcement response. All of this was really, this is information really we didn't receive for quite some time after the event. Multiple EMS agencies, and that's important because that had to be, again, we had people bleeding to death in that church in a town that had no emergency response, and to develop to get the mutual aid from surrounding communities and counties into that community, if you hadn't been planning for that, if you didn't have a plan for that, that would have been a tragedy because it never would have happened. But these things, the EMS agencies all converged on this little community. Also, that community, there's a small local hospital at one of our level 4 trauma centers that's about 15 minutes down the road from them. Actually, several of the walking wounded actually transported themselves directly to Connolly Memorial Hospital. And then some of the EMS agencies, as they were pulling patients out of the church, started to take them directly to Connolly Memorial because it was the first medical care facility that was within reach. About 11:45, STRAC MedCom, so we have a big communication center, centralized communication center, got a call from Connolly Memorial, our level 4 trauma center, that, hey, something's happening here. We have radio traffic, and all we can tell is that it's bad. But now we're starting to see patients, and they all have gunshot wounds, and it's, they're terrible. So this is these are high velocity gunshot wounds. This is something that the San Antonio needs to ramp up for. So University Hospital, it just so happened that we were undergoing a verification review, a focused visit. So I had 7 surgeons in the house. I was just fortunate at the time. I had all my resident surgeons. I had my entire senior trauma program staff and the chief hospital administrator. So it was easy to get the system, the center, ramped up based on what I had in-house. So this is the page I got that morning, or actually just after noon. And our pages they're so long, they actually come in multiple pages. But this is actually, it says Wilson County is responding to a mass shooting of possibly 30 patients. And basically this is to alert the system to update their capacity and capability to manage this event. This is the chain of events that were initiated from the very beginning. And you can see that right up front, within the first 10 minutes, you can see that there are numerous calls for help to the basically mutual aid. So numerous law enforcement agencies, numerous EMS agencies are actually engaged right up front to actually help develop this response. In addition, they had the insight to also start mobilizing our aeromedical providers. We have 17 helicopters in our region and probably about a half a dozen that are in very close proximity to actually be useful to this response. They were all engaged and all were en route to the scene. This is actually just sort of the timeline, the beginning of the timeline events. When it was all said and done, there were over 500 cataloged events, or actually meaningful decisions that had to be made in a period of less than 3 hours to get this to work. So this is basically the topo, or the aerial map of where the facilities are. The First Baptist Church is out there on the right. And what you'll notice at the First Baptist Church, there are no major roads into the city from Sutherland Springs. It's a very rural community. The Connolly Memorial Medical Center is down there at the bottom of the page, and then the 2 level 1 trauma centers, the Brooke Army Medical Center and University Hospital, are on opposite sides of the city. In a good day, these are sort of our response times with respect to air transport and ground transport. Sutherland Springs was about 43 miles from our major trauma centers. You can see that it's probably would have been probably a 30 or 40 minute ground transport and a very quick air transport. But what do you think happens to the air transport when you have an event like this? It's basically very highly controlled, and actually it's shut down for a while. So our aeromedical assets actually had to stay airborne and actually until the scene was completely secured so that we could ensure the safety of the aircraft and the crews. So even though the flight time would have been very short, with all the delays for sort of the safety delays, it really hampered the evacuation and recovery. So ultimately, this is where casualties went. Again, Connolly Memorial is about 13 miles. The 8 patients went to Connolly. Some went by EMS and some went by their personal vehicles. Brooke Army Medical Center is 29. University is 44 miles away. Brooke Army Medical Center got 8 patients directly from the scene. And initially, University Hospital got 5 patients directly from the scene. University Hospital is also a level 1 pediatric center. So there was a push to actually send the more grievously injured children to University Hospital for their care. And then ultimately, there were actually a couple of severely injured children that went to Connolly that were then evacuated from Connolly to the University Hospital. Again, just those little pieces look pretty simple, but actually effectively moving severely injured patients in sort of that chaos through your level 4, level 3 trauma systems, the efficiency with which the physicians and the nurses and the staff at Connolly moved patients through, did all the life-saving interventions, put on tourniquets, applied hemostatic dressings, intubated severely injured patients. It was just a very laudable effort. It was a magnificent effort by our level 4 trauma center. So Ryland was ultimately got to University Hospital. He's triaged as a level 1 alpha, which in our system is the highest tier of activation. At the same time, we were actually starting to get other injured patients from Sutherland Springs. And at the same time, we had a multiple shooting in South San Antonio. So we were getting 3 or 4 more other gunshot wounds from another scene. So again, you can imagine the chaos of a scene like that. Ryland had IVs placed. He was immediately begun with on massive transfusion and taken to the OR, had a damage control laparotomy. He had vascular shunting of his left upper extremity. He had a number of very severe soft tissue injuries that were temporized in that first afternoon. So of all of the casualties from Sutherland Springs, there are 46 casualties that were injured by gunshot wound. 25 were dead on the scene, and we had one unfortunate child that died in the operating room after really above and beyond efforts by our surgeons and nurses and anesthesia staff to try to save that child. There were 17 that were transported to the level 1 trauma centers. Interestingly, and this is important, 14 of those required operative intervention. So 82% of the patients involved in this active shooter MCI needed an operation, and 2/3 of them needed an operation right now, or they're going to die. So that's one of the important takeaways from particularly this type of event is these people are sick, they need surgical resources immediately. And again, like we talked about yesterday, time is life. You know, it's not an hour. Some people, it's 15 minutes. Those people need to get to definitive surgical care as quickly as possible. But certainly, one of the unique issues identified here is, unlike many of the other active shooter incidents that we've seen in our country that happened in the urban environment, where they're close to a trauma center, this happened in quite a rural environment, which actually presented some very unique challenges with respect to the care of these patients. And so to be able to integrate our level 4s and have them be completely functional, that was really a tremendous success for our trauma system. So Ryland was admitted to our hospital. He had 5 gunshot wounds. He was in hemorrhagic shock. He had a tourniquet applied to his left arm. And again, if somebody hadn't applied that tourniquet in the field, Ryland would have bled to death. He had multiple GI, GU, and vascular and soft tissue injuries, and ultimately had 24 operations while he was in the house the first time. So the evacuation timeline, again, by the time that the scene was cleared, EMS actually was able to enter the church between the sort of the EMS response and ultimately the last patient through transfer getting to the university hospital was just a little over 3 hours, or just a little under 3 hours. So really a tremendous system response. And again, that came with practice, that came with all of these system elements working together. And we've been working together on this planning type for an event like this for 10 years, hoping that it would never happen, obviously. So what were the things that worked for the system? Preparation was essential. We had multiple tabletop exercises and actually had a tabletop active shooter exercise integrated into our system preparedness plan just 6 months earlier. And we actually did another one just like that, actually more involved, about 3 weeks ago. Stop the Bleed education programs. Again, many of the first responders were law enforcement, and the law enforcement officers, almost to an individual, had tourniquets with them and began to apply first aid and bleeding control at the scene. To date, our trauma system has actually trained, I think, 8,000 people in our community with the Stop the Bleed program, because we're very aggressive with the training. So that's a plus for the system response. The coordinated pre-hospital response from the entire region, the mutual aid response was key to the survival in many of the survivors of Sutherland Springs. The level 4 trauma center, as I mentioned, a couple of those children would not have survived without that first stop at the level 4 trauma center for life-saving intervention. They wouldn't have survived the transfer to the level 1 trauma center. and the coordinated distribution of trauma patients. Again, there was a little bit of confusion there. As a matter of fact, I got on the phone with the trauma medical director, or the trauma surgeon on call at the other level 1, and neither one of us could figure out what was coming our way. So we actually had to sort of engage our MedCom system and our executive director to kind of make sure that these patients were routed appropriately. Because the EMS, great people, and they did a tremendous job, but their response was, who sees something like this on a day-to-day basis? Let's get these people off the scene and get them to a hospital. And it needs to be a little more thoughtful than that. I mean, obviously they were doing the right thing, but it needs to, particularly when they have a system that's got a plan and the resources, you need to actually sort of make sure that you're coordinating the distribution of trauma patients. Because I can tell you that neither Brooke Army Medical Center or University Hospital, even with our other three casualty shooting, were really super taxed by this. Again, it's part of what we do day to day. And again, it wasn't on the scale of Las Vegas. That will tax any system. But this is just what we do day to day. But we were able to, in a very short period of time, we started off with the capability when we got that page of having 3 operating rooms, 2 of which were occupied, to having 14 operating rooms, or the capability to run 14 operating rooms in 30 minutes. So that it's that type of the preparation that you need to do to be able to deal with one of these MCI events. And then some of the things that we don't think about is, the obvious, what do you do with the people that die, particularly if you have mass death. Many of your local morgues don't even have the capacity for this number of patients. So what do you do in that circumstance? We had a plan because we actually, again, we're fortunate that we're a big urban center, but we actually had a plan where we have refrigerated vehicles and we have pretty good engagement of our local medical examiner community on how to respond to this type of a mass mortality event. So some of the other challenges, again, I think our preparation on a system level was actually quite good. Prevention, obviously, it would have been great to have prevented this. And again, if you look at the news reports, there were missed opportunities to prevent this. Pre-hospital care, can't say enough good things about the care rendered by EMS. The bystanders, turning bystanders into immediate responders, we'll give that one a yellow. Many of the local bystanders were actually injured themselves. In the church, everybody was injured or dead. But our law enforcement actually did a really good job at becoming first responders as they secured the scene. The effective professional EMS response and care, again, can't say enough good things about our EMS folks. The pre-hospital notification and triage, there's a little ding on our system. The EMS system, the EMS, the law enforcement, the system itself were operating at 100% capacity. We were 30 minutes into the event before the trauma centers knew there was an event. So obviously, particularly if this had been an inner city event where the casualties were closer, that would have been a big deal with respect to mobilizing appropriate resources in enough time to actually save some of these people. Again, the trauma center care, the collaboration and the cooperation between the military and the civilian trauma centers was really fabulous. And the overall systemic response was good in our event. Again, even with the sophistication of our trauma system, our centralized trauma communication system, we have a medical operations system that's actually has been mobilized several times because we have so many hurricanes come up our way. But still, our communication systems did not operate optimally. Again, there was a lot of white noise in that first 30 minutes or 45 minutes after the event. So that's one of the things that you have to be aware of, that in the ensuing chaos of the event, some of your initial communications might not be what you expect them to be. So as you prepare, develop redundant strategies to deal with that. The trauma centers themselves, the trauma centers actually responded very nicely. Both trauma centers actually mobilized more than enough staff within 30 minutes. Their internal responses were really never overwhelmed. We do have a plan that had this been a bigger event, we can actually more aggressively integrate our level 3s in our community to support the response. The triage actually worked pretty well in our system. The internal chaos and noise in the trauma bays was actually very well managed, and the clinical decisions were very timely. Because of the bringing in the resources, many of our resuscitations were started in the emergency department in our resuscitation area and immediately taken to the OR, because we can actually sort of finish our diagnostics and the like in the operating room. So we actually got our casualties through the resuscitation area into the operating room, as they almost all needed operations very quickly. Again, our system actually worked very well. The system in Las Vegas worked very well. The system in Orlando worked very well. Those systems worked well because they were very mature systems and they were practiced, and everybody bought into those systems. That's one of the important things about the systemic response to an MCI event, is you really need to have leadership and engaged community that believes, even though you think it couldn't happen here, you need to actually prepare as though it will. Some of our opportunities to improve, again, prevention, no question. Communications, our communication systems, again, redundancy, things we can do to minimize the disinformation and the information distortion. Pre-hospital damage control, again, I talked about remote damage control yesterday, and we really didn't have the capability, particularly to push advanced resources out beyond the city of San Antonio itself. Stop the bleed education, again, even though we've trained 8,000, there's 2 million in San Antonio, so we have 199,992 to go, or whatever. So lots of opportunity there, and opportunity to improve the triage. And lastly, opportunity that the trauma centers really need to know up front about these events. But as a result of this, one of the PI opportunities is, again, because so much, once you get outside of the ring of San Antonio, you get pretty rural pretty quick. But that's true about many cities, and it's true here in Phoenix, it's true in Tucson, it's true in many of our communities, particularly in the Southwest, that you get pretty rural pretty quick. So what are you going to do then? So we actually developed a response very similar to what I mentioned yesterday with the remote damage control. We have one of the chiefs actually will take the 2 units of whole blood to the crew responding to the crash or the trauma. If we have another MCI, we actually have developed a process where we'll actually have an agency will pick up a large volume of whole blood and take it to the event. And whether that be ground or air will sort of depend on where the event is. But that way we can support events that are more austere, and potentially increase that window of survival to get some of those casualties back to the trauma centers. So some of the intangibles, remember, all incidents are going to start locally. Everybody that shows up is there to support you. Again, the outpouring of support, again, everybody that will show up no matter what, even in the media, is generally there to support you. The size of the incident is not always clear, particularly in that initial phase, again, that fog of war. So ramp your system up for maximal support. It's easier to dial back than it is to ramp it up when casualties are already at your doorstep. The event, again, our event precipitated a flight restriction, a temporary flight restriction. That's actually very common. The incident command system, the law enforcement, basically law enforcement is going to take charge of that scene, and it's important to actually have your law enforcement and your medical communities talking together. Obviously, we want to ensure safety, but we want to make sure that we have access to patient or casualties as soon as possible. And then ultimately, family assistance reunification are going to be things that you need to be concerned about or be aware of. Mental health, critical incident stress, and longer-term management. As I said when I started this talk, a lot of people are deeply affected by this, and we're just the care team. Your communities are actually really significantly affected by events like this. The community impact will be very long-lasting. The event is multi-day. This was a 10-minute shooting event, a 3-hour medical response. The on-scene incident management was weeks that community was basically locked down. Food for responders, for those of you that are EMS, beware of well-wishers that bring you food and the like. Make sure you get food from the local grocery. It's not that they would intentionally do anything to hurt you, but a little bit of old hot dog or whatever can probably wipe out a response crew. The press conference and the media needs to be controlled. Generally, your hospitals have a public affairs officer or something that will help you control this. Everybody will want to donate something, either to the injured, they'll want to donate blood. All of your hospitals, all of your your regions, your blood bank should be brought into the preparation phase, because if there's an event like this, there will be a line to donate blood that goes around the block. And obviously you have to be prepared with respect to the decedent management. So ultimately, the casualty distribution, we got 8 patients directly from the scene, 4 were transferred from Connolly Memorial, 8 patients went to BAMC, 9 patients went to university. The in-hospital mortality rate was 4%, which is really what we do every day in trauma care. Case fatality rate for all of our trauma centers is right around 4%, national average. If they can make it to your door, you will basically probably live up to the standard. But the event itself was 55%, because many that died actually died on the scene or died before they could get care. So these are just the faces of many of those, all of those people that were killed that day. And Emily Garcia was the one little girl that we lost. And terrible injuries. But again, that little bit of time in she was just at the brink of surviving, but just didn't quite have enough reserve. So time is of the essence in managing these MCI events. Again, recovery and psychological impact, particularly in your staff, your partners, your colleagues. Again, you're going to work hard, particularly if you're going to plan for a multi-day event. Make sure you're a leader. If you are a leader, plan for rest for your teams, even if they rest in the hospital. So in summary, I think that we had actually a very effective and efficient disaster response, but it was built on the framework of a very highly functioning trauma system to start with. We also are very keen on our local regional threats. Didn't expect this one though. Didn't expect a rural active shooter. But we were able to adapt to it based on our plan for our urban active shooter. It's important to, again, some of the things that you need to focus on are your communication, your triage, your first responders, for those of you we talked about doing Stop the Bleed in your communities, and those intangibles. So, There on the left, that young lady is Dr. Lillian Lau. She is our pediatric trauma medical director. She actually took care of the large majority of Ryland's care. Ryland was in hospital for 68 days, in the pediatric intensive care unit for a majority of it. He had 24 operations, countless hours of rehabilitation and care by a really tremendous staff of nurses and other hospital support programs, not to mention, obviously, the physicians and the administration. So on January 12th, after 68 days, Rusty Duncan had been continuing to sort of visit Ryland, and Ryland said he wanted to ride in the fire truck. So on January 12th, Rusty came from the Stockdale Fire Department with the biggest fire truck he could find, and actually gave Ryland Ward, the little boy whose life he saved, a ride home. So this past Monday, again, is 1 year since the anniversary of Sutherland Springs tragedy, and Ryland continues to improve. He still has intensive physical therapy and occupational therapy, and obviously behavioral therapy. But you can see that's a picture of Ryland. Actually, the news did a photo or did a interview with him on Monday, and that's Ryland there. It's basically a sort of a normal active 6-year-old now. So 96% of the people in this that actually survived the initial onslaught that were evacuated to the hospital, 96% survived. That would not have been possible. The outcome would have been much worse if it hadn't been for a highly functioning trauma system and the heroic efforts of law enforcement and EMS on that day. So thank you very much.